So yeah, so I'm Judith Bubbear. I'm a consultant at Royal National Orthopaedic, and Sam is, well, very local to me where I live, actually, a primary care nurse. And also I think she's got the best title because she's a Queen's nurse. And we are going to race through some things that Sally's picked up on. And thank you, Sally, because you feel you've overshared, but actually, like, we really should be talking about these things. And I'm really passionate about it. And I think Sam's going to have some tips that might add to some of your stories. So basically what we're going to do is I'm going to give you a bit of background on the screening, why we do it, how useful it is, and then Sam is going to come in with the practical kind of how can you do things. And we're going to cover cervical screening and breast, and we're going to say something about bowel cancer screening, blimey. And now my slides won't progress, which is really helping. Let's try this way. There we go. Lovely. Did you think I could drive a computer? So cervical cancer is most common in actually relatively young women between the age of 30 and 35. And it develops slowly. And that actually makes it a good disease to do screening because it presents later. And therefore, you want to try and pick it up as early as possible to have good outcomes. And just to remind us where we're talking about, the cervix is the bottom of your womb that comes into the vagina there. And it's accessible through the vagina, can be seen and visualized. Symptoms of cervical cancer might include things like bleeding or pain or discharge, and anyone who's had who has a cervix and has had any type of sexual contact with anybody is at risk of cervical cancer. And screening is one of the best ways to protect yourself. So it's not the most common cancer. 1 in 130 women in the UK will be diagnosed with cervical cancer, but this is a real success story in terms of screening. So NHS screenings reduced deaths by about 75% since this started in the 1970s. And the other thing just to mention that's reducing cervical cancer is the vaccine against HPV, which is the human papillomavirus that I'll mention in a little while. But this is a vaccine that's offered to younger people because we know that's really important for developing cervical cancer. So this is the screening program in the UK. So you're invited for screening between the ages of 25 and 64. And now you're invited every 5 years. It used to be every 3 years. It's not a test for cancer. It's a test to try to prevent cancer. And I'm sure most of us know they try to collect a small sample of cells from the cervix. And what has changed in recent years is now not everybody's cells get looked at on the microscope. They're checked for this virus called human papillomavirus. And if that's not found, you don't need any more tests. But if HPV is found, in particular, some of the high-risk types of HPV, then they look at the cells. So just to mention HPV, this is actually really, really common. Almost all of us will get some type of HPV in our lifetime, but some of the higher risk, and that's just how they classify them, HPVs can cause cancer, including cervical cancer. And you can get HPV by any type of skin-to-skin contact. So not just penetrative sex, so sex toys and touching and oral sex all can transmit HPV. And most of the time our bodies actually get rid of it. But if it stays in our body, it can lead to changes that lead to cervical cancer. And now we understand that if you don't have one of the high-risk types of HPV, it's really unlikely you'll get cervical cancer. So the screening for cervical cancer is really effective and has worked really well to bring down rates. But as Sally's mentioned, it can be challenging. So I'm going to hand over to Sam, who is going to give you some practical tips on this.
I will unmute myself. I would also like to thank Sally for sharing those experiences, because these are not uncommon things that we still hear in general practice when people attend for their cervical screening, and is quite sad. I think things are moving on, things are changing. We still need to improve, and we still need to make every person's experience who comes through cervical screening as dignified as we can. But I think the important things that I wanted to discuss is about empowering you to then jointly, with a shared care decision, support your screen. And everything that we should be doing is about your safety and comfort. And what Sally has echoed, things like finding out about the bed sizes. All surgeries now should have access to beds that can be lowered to really low levels, so that there should be a streamlined access for all people to be able to get onto the beds. And there should be in each GP practice something like that. So one of the things that we're really keen on in practice these days is, if you have any concerns about what is going to happen within the room, don't leave it to the date of the appointment. Don't book the appointment and then come in and it be, is there a bed that's going to fit? What about the positioning? Book an appointment time before with one of the sample takers. In most practices these days, the sample takers are the nurses. Generally most GP practice will be one of the female nurses, and they will be female. But book an appointment. You'll probably know most of them. They're your practice nurse. But book an appointment, come in, talk about it. We do this a lot with our first screeners. So the people who are in that 24 bracket, sometimes they just come in, sit with me. I go through what it is, because a lot of people are accessing information TikTok these days, and we don't really like that. So come in, look at the equipment, hold the equipment, look at the bed, talk about what's safe and comfortable for you. So you don't have to necessarily lie on your back with your legs apart. We can position you on the side where you just lift your legs up gently. We can keep knees supported. We can use pillows to support the leg positioning, and all that can be negotiated way before we even do the sample. Some things that we're very keen on as well these days is looking at the size of the speculum, which is what we use to put into the vagina to open up to see the cervix. And we can teach people to self-insert so it's more comfortable. So we can teach you how to just insert it. Then all we do at the end is just opening it up, and we're seeing where the cervix is. And these are very different experiences from what I heard from Sally with her first experience, where it is very much, you must be in that position. It's much, much different these days. It's all about individualizing care to then visualize the cervix. And as Jude alluded to, the cervix is a muscle essentially, isn't it, Jude? And if you're not relaxed, it hides, and then we can't find it, and then it can be quite uncomfortable. Shouldn't have to be like that. You can also ask just for the examination to be slower, and then we can just slow it down. And so that kind of reflects on my last part, which is you are in control at all times. You talk to the person who is performing the cervical smear and say, yep, stop now, pull back, let's just wait, let me have a go at putting in the speculum, or I'm not comfortable, move me, and we can adjust you these days. Because as we've been saying, it's now not about the old-fashioned, what we call smear, where we used to put in a wooden spatula and scrape cells. This is about using a brush system to take the cells off to look for the HPV. Jude, can you go to the next slide? The other important thing that I want to start talking about, and this is, I think, going on to what Sally was talking about, is having information about the fact that also, if the cervical screening is not suitable for you, that there are these new, what we call self-swabs for HPV. And what they are, it's a new system that's coming out. We're very cognizant. We are listening to women who don't want to come into surgery for whatever reason. And actually, for our non-attenders now, we're using this new system where, if you can see the swab on the slide, the top one is the swab that you would use. The Tampax and the cotton bud are for comparison. And you only need to insert, if you can see, to that tiny red line, and you just need to insert that into your vagina, put it in, pull it out, put it into the pot that comes with it, and you send it off. So much better system. much more suited for patients with mobility issues who haven't been for screening. But what you need to do is ask your GP practice. Some areas aren't doing it. We certainly in North Central London are. So you go to your GP practice, we click a button, it sends you the system and you can do it. So again, this session here is empowering you that if you really don't want to go for your cervical screen, go speak to your practice about the self-swabs. It's going to be one of the ways forward. And that, I think, is all. Yes, so a really good question, Joanna, actually. What it does is it will identify the HPV virus. And when they look at the virus, if it's high risk, you may then still have to come into one of the colposcopy centres for them to then do a formal check to make sure that they then look at your cervix and then do the deeper screen. But it's a really good starting point. But very good question, thank you.
Okay, we'll move on to breast screening that we've already sort of started to touch on. So breast cancer is much more common. It's the most common cancer in the UK, and 1 in 7 of us is going to have breast cancer in our lifetime. The majority of people with breast cancer are over 50, and the highest rates are in that sort of late 60s. But again, a real success of screening where mortality has reduced by 45% since the early 70s. And that obviously is screening and the improvements in treatment. So we talk about a mammogram. And in the UK, we're invited for screening between 50 and 71. And this uses X-rays. So you can see at the bottom here, there's a picture of somebody with their breast in the mammogram, in the machine. And what it does is it takes an X-ray, and up here at the top you've got a normal mammogram, and it looks a bit odd, but it's both breasts kind of put next to each other. I always think it looks a bit funny. And the point of this is to spot a cancer before you can see it or feel it. And the idea is that the earlier we find a cancer, the less likely you are to need a mastectomy. You could have less surgery, and it's more likely that the treatment will be successful. And I just have this example here that this white area here is a breast cancer that's been seen on a mammogram. And just before we get onto the practical tips, anything thinking about breast cancer, I'd be remiss not to remind us all to check our breasts. And I'm just showing you this slide, and if you want to come back, I think we're recording that you can have a look. But you want to know what your breasts look like and what they feel like, and to regularly be checking your breasts, your armpits, and up to your collarbones for any changes. And personally, I do this in the shower because I find that's the easiest place for me to do it. Other people find it easier reclining, so doing it when you're sort of lying in bed. But it's just really worth getting into a rhythm of remembering to check your breasts and to do that regularly, because the earlier we spot any changes, the better. So Sam, what are your practical tips for this one?
So I feel that Sally, again, has slightly taken the wind out of our sails, really.
Brilliantly, yes.
So brilliantly and beautifully described all the issues related to breast screening, which I think are slightly more impactful, actually, than cervical screening, because there is a requirement for some positioning. And yet Sally is also, slide 2 that I'm about to show you, she's also taken the wind out of my sails, really. So again, the practical tips that we would suggest you could consider is about asking before you accept the appointment where you're going to be having the appointment, because I think Sally didn't really reference the fact that some of these the mammograms are on vans, which may be in a Tesco's car park, so they may not be in a static site. So when you, Sally's just said sorry. So when you get your invitation, I think one of the most important things before the appointment is to inform the booking staff about your diagnosis and about your comfort, your positioning, because then they can rebook you, because maybe being on one of the vans is not the best place for you. And in the static sites that they offer the mammograms, they have facilities for wheelchair access. They have seats and chairs that you can sit in, so that you can sit whilst the picture that Jude showed you, and then they can bring down the X-ray machine, so it's much more on a level that's suitable for any position. I think it's really important to talk about previous fractures and pain areas, so that they're aware when the radiographer is positioning you, because it will require some positioning you. And again, just gently suggest to them that they just take it slowly. I mean, I think they should take it slowly with all women, but yeah, just take it slowly, because your safety is the priority. And again, just to reiterate, they can do seated mammograms. So ask for that. When you get the letter, phone and say, I need a static site and I will need to be seated with the mammogram. But the next slide, which Sally has beautifully already eloquent, is if you can't, if standing is difficult, you can use a wheelchair. If with this severe, if you need to tell them about your spinal curvature, and let the screening unit know in advance, really, because they'll give you a longer appointment time, they'll assist you, and then we can need to consider the alternative imaging. So I put it in a very medical term. Sally put it in a more human term, which is they don't necessarily need to do a mammogram. They can offer you an ultrasound and an assessment beforehand to see what risk you are. So it's all looking about high risk and where you need, where you can kind of sit within that. So I think, again, it's about opening that dialogue, and ultrasound the way forward if you really can't manage with the mammogram. But again, talk about it. So, Jude.
Brilliant. Yeah. Thanks, Sam. So I couldn't leave without, I know this is not technically women because it's everybody, but you know, the bowel cancer screening service has started and is really important, and I just want to debunk any problems with this one as well. So bowel cancer is the fourth most common cancer in the UK. And my slide is messed up. It's supposed to say screening is a test to look for blood in your poo. And it's offered to everybody aged 50 to 74. I was delighted when mine arrived in the post just after my birthday. But again, this is about picking up possibility of cancer before you get any symptoms or any problems. And all it's doing is looking to see if there's any blood in your poo, because blood in your poo is a sign of cancer, and you may not ever see it, but we can detect it. And as you can see there, and I think Sam's going to go over, it's you collect a bit of poo and you stick it on a little brushy sample thing, and then you stick it back in the post. So you don't go anywhere near a doctor's for this one. But Sam, how can we do this to one a bit easier?
Absolutely. I think some practical tips, and this is for anybody really. But I always tell the story as well, that my father had great joy in doing his for the first time, because he really doesn't like their poster.
Vulcanized rubber became more popular.
So simple tips that we can give you if your shoulders or your hands or your mobility means that you can't quite, you know, scrape it from within your bottom, is actually just put a clean container or some paper and then use it into that, and then using the small stick which it comes with it, just tiny bit, and then put it into the tube. So you don't need to be doing anything particularly very specifically technique wise. It's just a question of getting it however you can onto the small stick and into the tube. So again, just some simple tips. Don't bend or strain, or definitely keep yourself supported when you do it. Take your time. There is no need to rush. And as Jude has already alluded to, there is only the need for a very, very, very small sample. And it's quick and it's easy, and then pop it into the post. But again, I think I can only reiterate what Jude says is don't consider it something not to do because you're worried about the technique of getting the poo onto the stick. It doesn't matter. The labs will tell you if there's a great drama with it. And I can tell you that in 9 out of 10 cases, there's never a problem. And again, anecdotally, the only other human, and Judy's going to laugh at this, that's had a problem with this was my husband, who let his stick dry before he puts it into the tube, because he was reading the newspaper before he finished whatever he was doing in the toilet. So that's the kind of a human error that happens. It won't be because of the technique of getting the poo onto the stick. So please, and I tell that story all the time in general practice all the time. You cannot make a mistake unless you decide to read the newspaper for the rest of the time on that toilet.
Wonderful.
Love it. And there's just some key messages that I think both of us really wanted to just reiterate, really. You are entitled to reasonable adjustments. The screening should be adapted by us. It shouldn't be avoided by you. We should be able to adapt it to make it tolerable, not painful, and as comfortable as possible. That may include longer appointments. It may include somebody coming with you just to help you out, help your positioning, hold your hand. That is not a problem. Also, both with breast screening and cervical screening, stop it. If you don't feel safe or it hurts, you stop it. You are in control. The clinician is not in control. So you guide how it's done. And I think this is a really, really, really good message that I was reading, and I like this one, is that OA changes how care is delivered, but it should never stop you receiving it. So encouraging those open discussions, booking an appointment before you attend the screen, sharing your concerns is never, ever, ever going to be a wasted appointment for anyone. And advocating for yourself is not difficult, it's just being safe. And I would be absolutely devastated if I heard that someone said, oh, I didn't want to waste her time, I just decided not to go. No one ever wastes our time in general practice, certainly not with the practice nurses. So just come and talk to us about it. And we will happily talk about mammograms as well. We can call the office and talk about getting you on the static mobiles as well. So just speak to us about both events, really. Thank you for listening.